This video presents a clinical decision pathway for type 2 diabetes management. It is a modular framework for choosing, reviewing, and optimizing medicines based on patient comorbidities, based on the NICE Guideline NG28. The foundations of care include holistic management, focusing on diet, healthy living, and establishing sick day rules. Shared decision-making balances effectiveness, protection, barriers, and cost. Prioritize the condition posing the highest immediate risk for patients with multiple comorbidities. Golden rules of prescribing involve sequencing medications, titration to the maximum tolerated dose, and using standard-release metformin unless not tolerated. Always check for a wrong diagnosis if the response to medicines is poor. For patients with no relevant comorbidities, the standard pathway begins with modified-release metformin plus an SGLT2 inhibitor. If targets are not met, add a DPP4 inhibitor, followed by a sulfonylurea, pioglitazone, or insulin-based treatment. Note the review loop for immediate hyperglycemia symptoms. For patients with atherosclerotic cardiovascular disease, first-line therapy adds subcutaneous semaglutide to modified-release metformin and an SGLT2 inhibitor. If targets are not met, move to second-line with sulfonylurea, pioglitazone, or insulin. For heart failure, SGLT2 is critical in first line. If targets are not met, escalate by adding a DPP4 inhibitor. Further escalation includes sulfonylurea or insulin-based treatment. Note the contraindication. Do not use pioglitazone. For high BMI and early onset diabetes, the foundation is modified-release metformin plus SGLT2 inhibitor. The accelerator considers adding a GLP-1 receptor agonist or tirzepatide. Escalation involves sulfonylurea, pioglitazone, or insulin. For chronic kidney disease, treatment varies by eGFR. SGLT2s are contraindicated below 30 milliliters per minute. Escalation for low eGFR, if DPP4 is ineffective, includes pioglitazone or insulin. For frailty and elderly care, first line is modified-release metformin monotherapy. The goal is the smallest effective number of medications at the lowest effective dosage. Exercise SGLT2, caution regarding hypotension. Reviewing and optimizing therapy involves a pre-switch checklist and specific rules. Do not offer GLP-1RA and DPP4 inhibitor together. Continue SGLT2s for cardiovascular and renal benefits, even if HbA1c targets are missed. Rescue therapies are used when first and second-line options are exhausted. Options include insulin-based treatment for symptom control, sulfonylureas, which carry a risk of hypoglycemia, and pioglitazone, which is strictly contraindicated in heart failure. This clinical decision matrix provides a summary of first-line recommendations and key notes based on patient profiles. Always assess CV status, renal status, and frailty before prescribing.